Welcome, everyone. We're just waiting one more minute to kind of slowly allow people to roll in to the meeting. But then with that, I will start as soon as possible after that, not to take too much time away from the speakers. Nice to see you here, Dandy. And also everyone else who is joining. Right. With that said, as the time is moving along, welcome everyone again. I'm so happy to have you here to our third session of our 5-part World Forum Capacity Strengthening Training series. Over the past 2 weeks, we have already explored important dimensions of prevention, starting with gender and trauma-sensitive prevention approaches, followed by a very powerful session on youth engagement last week, where young participants reminded us that meaningful participation means more than simply having a seat at the table. And then today, I'm very much looking forward to share that we will move further along the continuum of care and focus on gender and trauma-sensitive treatment and recovery, which remains an incredibly timely and important topic, because while awareness has grown around the different pathways that may lead women and men to substance use, and around the importance of gender-sensitive responses across prevention, treatment, and recovery, the gaps still remain. Women continue to face substantial barriers in accessing treatment and recovery support, and some of these are more practical, such as limited childcare, financial dependence, or the lack of women-specific treatment services. Others are more social and structural, such as stigma, discrimination, fear of losing custody of children, or simply systems that were not designed with women's realities in mind. And these barriers have real consequences because the data from the World Drug Report 2025 doesn't lie. It shows that while approximately 1 in 7 men globally access treatment for drug use disorders, only 1 in 18 women do so. And that is a very striking gap, particularly at a time when the gender gap in substance use itself has narrowed significantly in many settings. But stigma does not only affect women alone. For many people in recovery, women and men alike, stigma remains one of the most persistent barriers to seeking help, sustaining recovery, and feeling accepted within their communities. And at the same time, we know that connection, dignity, and community support are essential parts of recovery. And that's why today's session is not only about understanding the barriers, but also learning from practical responses and community-driven solutions. And I'm very honored to have with me today an incredibly panel of experts, and with the first, and I'm very pleased to introduce our very first speaker, Mulka Nishik, who will open today's discussion by focusing on stigma reduction in recovery processes. She holds a PhD in business, law, and social sciences, specializing in criminology and social justice, and an master in desistance and from crime, and her work focuses on the intersection of substance use and drug-related offending, with particular attention to the social and structural factors shaping vulnerability to substance use, crime involvement, as well as a pathway towards resilience, recovery, and desistance. She currently serves as the Faith and Youth Project Coordinator at the International Society of Substance Use Professionals. Mulka, the floor is yours. Are you muted, Maybe.
As we said, it's always a trouble and struggle with the technology. So I'm so sorry. I was saying I'm very honored to be here, and thank you, Cressida and WFAD team, for organizing the sessions. And it's very important for us also to be able to contribute and be part of this. And in my personal name and also on behalf of ISOP, I thank you for engaging us. And I'll just say one sentence or two about ISEP. So we are the international network that unites and connects and shares the knowledge across the substance use workforce. We work with national chapters and have more than 50,000 members. So it's a great also way for us to engage with everybody and also to bring the knowledge and expand the access to knowledge and collaboration across the globe. And on today's presentation, I will focus on recovery and stigma around recovery. I do also like to mention a lot about women, but we have a perfect speaker today that will talk about gender sensitive treatment and recovery services. So I will not mention much about that. Just for the kind of common knowledge, recovery is a very contested term. People do not know what recovery means. Consensus about the meaning of recovery has not still been achieved, although it has been in very important documents for the past 30 to 50 years. And in Europe, especially, it has been really lately only recognized in some drug strategies, especially in Eastern Europe, but we do have some experiences from the UK, UN, and also the US, where the majority of recovery research has already been done. And I would just say that for me personally, to explain this in a very plain language, recovery is a process through which a person is kind of enabled to across and transition from a problematic use to being a very contributing member of society. So all of these services and practices go from detox, then community-based services, recovery services, help groups, self-help groups, mutual help groups. So this is a very long process that I will explain a little bit later. And these, in defining recovery, it really is about these couple of things: reducing or gaining control over the substance, making all of these positive changes in one's life, improving health, well-being, and increasing this participation in society, which is really important for the recovery processes. And this slide has been presented on many conferences and taken from my colleagues from Harvard University, and illustrate so well that what we know about the recovery process. So the first thing I want to mention is that 60% of people who seek recovery, so who had a severe addiction and they seek recovery, eventually do achieve recovery and sustained remission of symptoms. And this has been proven by Bill White, who is an eminent researcher and figure in the recovery. So from the beginning of the slide, we know that from onset of addiction until 5 years of stable recovery, it approximately lasts 17 to 18 years. So this is a very long period. And we know for the first 4 or 5 years, people report self-initiated attempts to stop. So people do try to stop, they fail. And at the point of 5 years, they seek help and kind of continued support for the next 8 years. And they achieve full remission around 1 year into those 5 years. And for the next 5 years of abstinence or remission, they are very critical for someone to be in a stable recovery. And this is also same across all the chronic, let's say, disorders and diseases, same for cancer. So if a person having a chronic disease like a cancer or addiction or drug dependence, however we want to name it, is 5 years in abstinence, they can really achieve this stable remission. And from the recovery field, which I have been part of for almost 2 decades, we always think about recovery that we need something to measure it. So some of my colleagues came up with the recovery capital kind of concept, and it's the breadth and depth of internal and external resources that someone can use and touch upon to initiate and sustain recovery from severe alcohol and drug problems. So this process is or the measure is divided into personal, social, and community resources. And while all of the personal and social capital or resources seems necessary to initiate the recovery, it's the community that is critical to sustain it. And this is really kind of opposite to what we know about the acute treatment or medical view of addiction and how someone can recover, because for the recovery field, it's important to understand that acute services can get you to one point. And of course, we need a detox. Of course, we need to address underlying mental health and physical health challenges that one has. But it's the community, the family, and our activities inside the community where we live that kind of see us through this process. And as we've seen on a previous slide, it's a quite a long process to achieve first year of recovery or early recovery, and to sustain it for 5 years when it really becomes self-sustaining. And for those of you who work in prevention, just to understand this concept, we created this kind of equivalent of recovery and prevention kind of processes and services that are key, or I would say protective and risk factors in prevention. So for prevention field, all of these protective and risk factors can be translated also into the recovery capital or pro-recovery culture. So the risk factors like substance use, broken families, peers who are using alcohol and drugs, school dropouts or losing a job. All of these are also kind of negative recovery capital or negative recovery culture, while also protective factors like families, positive activities, non-using friends, having a job, doing also continuing with education, they can see also as pro-recovery culture. So there is an equivalence, and for us in recovery field, it took years to kind of explain why prevention and recovery do have lots in common, and that those activities and services are pretty much the same, only for different populations. For those who have already been affected by severe alcohol and drug use. Okay, so I will not go into this, but I will say that for us in recovery field and also in every field related to physical and mental health, stigma is a profound barrier for recovery. It's a mark of disgrace, of social disapproval, of negative stereotypes and attached to a person, to a group, based on a really specific characteristics such as, using drugs, social status, behaviors, and it kind of separates, labels, and discriminates against individuals, often causing shame, isolation, and diminished self-esteem. And this is really important for us when Asya is presenting that women do have it harder. They have more barriers, stigma is harder, and very much, especially in some cultures, and it's a great barrier that we haven't still resolved how to support women in recovery processes and how to help them achieve recovery. And from the standpoint of recovery capital, we can see stigma being linked really to a negative recovery capital. So personal negative recovery capital would be self-stigma. Social would be membership of stigmatized groups and excluded groups, and community-based negative recovery capital or stigma would be structural barriers to integration in society. And this problem has been really traditionally used to kind of discuss about stigma. It's been used to discourage unhealthy behaviors grounded in a policy and criminal law, but it also kind of has a negative influence in terms of being the fourth stigmatized condition by the World Health Organization data. And for us to prevent internalization of this, we need of stigma and self-stigma, we need really lots of community-based resources and things that we can do to support people to seek help and stay in recovery. So barriers to treatment and recovery, this is for women particularly. I will not go into it, but because Asya will probably talk more about it, but I can just say that across individual, social, and societal or structural barriers, the most prominent barrier for women is being really fearful or having the issue of children being taken into custody care and removed from the family. And for us in recovery field, we have for years tried to invest more into services and practices and policies that could kind of support women with children to enter treatment without fear that their children will be taken away from them. And this is a problem across the globe, the lack of support for families, being victims also of domestic violence or sexual abuse, and perceiving that all of these problems are more important to take into account than personal recovery. This is something that we are still working on and need the support of society and professionals to improve. So we have done a lot of research into the stigma and the attitudes that are towards people, not only in addiction, but people who are in recovery. And this 5 years journey allows people to integrate only if the society allows them to integrate. And we have asked all of these questions that you see on the screen about we first asked the general public and the professionals who are offering help to people who are in recovery or who are seeking recovery. And all of these numbers are almost the same, in a couple of percentages difference. So these people who are struggling with addiction, who are affected by the addiction, they can go as far as society will allow them or won't support them. And we hear professionals in alcohol and drug field bleating endlessly about the languages that are being used or what the stigma is. But when we asked all of the questions, would people, for example, would you allow people in recovery to look after your children? Would you live them beside you? Would you let your children play with children of people in recovery, or enter into a relationship with someone in recovery? These data are devastating. So the conclusion when you see all of these data is not in my yard, not in my family, not in my workplace, and you can recover somewhere, far away from me, but I will not allow you to live a normal life. And this is very devastating. And it applies to the clients, it applies to family, but it also applies to the children. And this is the extent of stigma in addiction field that we need really to address by and Warren will talk about this, by celebrating recovery, by making recovery visible, by showing the examples of people who successfully recovered and showing the data, what happens when someone who was in a severe addiction enters recovery for many, many years. So we have actually done this. And we took this research in last wave was in 9 European countries. A study before that was in 15 European countries and also the UK. And there are few variation in the health factors that we investigated in other countries, in Sweden and in the Balkan. And I'm showing the data from the last wave. So we investigated kind of what happens to people in addiction. So these data on the slide are in addiction, in active addiction in the Balkans, in 4 countries in the UK and the Sweden. And this data set provides kind of comprehensive analysis about health, legal, financial, work, and family-related issues in these countries. And the responses are the response rate was around 610 individuals from all of the countries. And finding indicates when in addiction, people find it very difficult. They have the contact with the criminal justice system. They lose their driving license. they have criminal charges and arrests. They are not able to pay bills. They frequently kind of miss school or work or drop out of school, and the levels of family violence are very high. They do not volunteer, they do not contribute to their communities, and the data are very kind of frightening. But the data on this slide present really what happens when people are in recovery. And these results suggest, as you can see, that compared to other countries, and these are just significant outcomes, including tobacco use, damaging property, family violence, they all drop. They drop from 70% to 2% or to 40%. So these increases and changes in behaviors are very significant. And the most kind of stunning change was in volunteering, so in contributing to the communities. And some of my colleagues previously have really kind of caught this change as a very important, and they kind of investigated, okay, so what's the percentage among the general population? How many people who never use drug volunteer or contribute to their communities? And the percentage was 30-something%. So basically, people in recovery volunteer and contribute to their communities 2 times more than anybody who never had any addiction problems. And if you look at the slide that I presented you about the consequences of stigma and how people don't want to live even beside people in recovery, I can just say it's better off to have a neighbor that's in recovery than someone who has never been affected by addiction. People do contribute more. People do start school again. They do not perpetrate family violence. They're able to pay bills, and they are not in the contact with criminal justice system. So what can we do? What can we do to make recovery more visible and to contribute to the conversation about stigma and celebrating people in recovery? We do have we don't have to go from scratch. We have lots and lots of global, local, and international initiatives that are positive, that make the changes and that contribute to recovery field. One of them, and I'm really proud of being part of this also in the Balkans, are building inclusive recovery cities. And this initiative, please, also I will provide all of the necessary resources to Cressida. Have a look. This Warren can tell you also more about it. And the inclusive recovery cities are actually local solutions to the local problems. So bringing key employment services, social services, recovery community, municipalities, and really talking about how can we do better on the local levels. I have personally been involved also in a couple of initiatives with women. We have participated in Recovery Film Festival, co-produced the film. This film is also available. We have featured women in recovery and how they recover using a photo voice, which is a very inspiring tool to research into the social problems. We have also created a book about women in recovery, showing the pathways, showing what needs to be done, and how do we support women to recover more and to seek support in their recovery journey. So I will not take up much of your time because I probably am near to my limit. I just want to conclude this, that recovery needs to be gendered, needs to be relational. Women in recovery have different journeys. Also, young people in recovery have different journeys. It's very complicated with stigma, with cultural expectations, societal judgment, and everything is interconnected: personal, social, community, recovery, capital. All of these domains need to reinforce one another, and we need a holistic and systemic approach to recovery. Stigma remains the major barrier to recovery, and we need to do more. Motherhood also adds a different layer and vulnerability to stigma. We also need all of these supportive relationships, support from a family, compassionate service delivery, critical sources of social recovery capital, and also NGOs, practitioners play really transformative role in all of this. You facilitate empowerment, connection, co-production, organizing all of these events, and for facilitating post-traumatic growth and long-term recovery successes. For me, I really like the participatory methods, and if you want to know more about what we have done, 15 minutes is not enough. So Cressida will send you all the resources, and also feel free to investigate a little bit ISOP website. Thank you so much.
Thank you, Mocha, so much for your presentation. You've done an incredible job to kind of summarize or put this very complex topic together in 15, 20 minutes. So thank you so much for that, and highlighting not only the recovery capital or definition of recovery, but also diving into how recovery is possible, and that indeed the stigma is shocking. I was very much, even though I've seen these numbers before, I get shocked every time that there's such a large number of people that do have this kind of prejudice about people in recovery, and that it's very much needed, continuously needed to work towards that, but that there's also great initiatives already out there. And thank you for sharing about the recovery cities. And I'm sure later today we'll also hear more about other kinds of initiatives also. But thank you so much, Molka. I think one short question before we move on. Since you mentioned the recovery city, for organizations working with limited resources, what are the first building blocks of creating a more recovery supportive community or established recovery cities? What would be your advice?
So we have done this with small amount of resources, with zero resources as well. We also had a Balkan project which Cressida was part of. Very happy, it was a great collaboration. But for us, it's the most important thing is to sit together, to gather all the key stakeholders in the local community and start the conversations. We can always ask for a space for this from municipalities, from different actors, and we need to include recovery community and people with lived experience of recovery to share their experiences. And this is the key for inclusive recovery cities. And this is also the model that everybody is talking about: nothing without us, for us without us. We need to provide the space and platform for people in recovery to contribute. One of the I would say requirements for the recovery city is really to celebrate recovery, to organize event where recovery will be visible. And I didn't have time to talk more about the professionals in medical field and how stunned they are that actually there is a recovery community, because they only see severe cases of people with long-term problems and addiction. And they didn't really have a contact with people in recovery. It's stunning in the digital age that they cannot even recommend online groups, support groups, and all of that. So taking small steps like that, celebrating recovery, organizing meeting with stakeholders, also reaching out to us. I mean, inclusive recovery cities are now growing. There is almost like 40 cities that sign up to be inclusive recovery cities, and then take it from there. there is a recovery charter. There are things that major or a municipality people can sign, and it just grows, step by step, very small steps. But the first is to sit together to kind of provide a platform for people in recovery and celebrate recovery and make it more visible.
Thank you so much, Moka, for addressing and highlighting that, especially also with the healthcare workers, as you said, that is oftentimes they also portray a lot of stigma on others who need their support, actually. With that said, thank you so much for joining us today. And I mean, there will be maybe more time towards the end of the session also for more questions. So if you have any further questions for Moka, please put them in the chat or in the Q&A box, and we will hopefully have time towards the end of the session for more. For now, I would like to introduce our next speaker, Asia Ashraf. She is from Pakistan and is a mental health disorder and addiction expert with 19 years of experience in treatment, rehabilitation, policy implementation, and gender responsive care. She's also a Humphrey alumni and ICAP 4 certified professional and serves as the secretary to the Financial Committee on Drugs. And she's also a global DDR trainer, and she currently serves as the director of the rehabilitation and consultant psychologist at Greenfield Hospital Psychiatry. Asia, the floor is yours.
Thank you very much. Thank you very much. I just need to start sharing my presentation. It is already? Yes.
It was there. It was there, but now it's gone.
It is second.
So now, yeah, now it's loading. Yes, just put on presenter mode, and then it should be fine.
Okay.
Yeah, perfect.
Yeah. So okay, I am able to see my presentation, but I am not able to see the audience. I hope audience is able to see me. I don't know.
Yes.
Okay, thank you. So, good day, ladies and gentlemen. It is like pleasure to be among you all, and thank you very much, WFAD, for organizing this very important capacity building training series, and for giving me opportunity to share experiences from our work at Greenfield Hospital of Psychiatry. Before we talk about treatment, I really want us to take a pause for a moment and think about this. Women who enter into the care, they are not carrying only substance abuse struggle. They are carrying with them, as Mulka mentioned, trauma, fear, guilt, shame. So what I have seen that sometimes the most powerful part of the treatment is not the intervention itself. It is creating a space where women can feel supported, connected, understood, and being heard. So today I'll be talking about how gender sensitive and trauma informed practices actually transform the way we engage, care, support, and the women in the recovery. So in today's presentation, I'll be briefly talking about substance use landscape in Pakistan with patterns, treatment capacity, and unmet needs, and also a connection between trauma and addiction. And most importantly, I'll be talking more about the practical strategies to create gender-sensitive and trauma-informed care, which we are actually using at Greenfield Hospital of Psychiatry. So just starting with the substance use landscape in Pakistan. Pakistan is situated in South Asia, and it's a transit corridor and consumer of illicit Afghan drugs. And the data we have, it is very old by the UNODC in 2013. The substance abuse situation is quite changed in nowadays. Currently, crystal methamphetamine or ICE is a growing challenge in Pakistan, and its abuse is increasing in the educational institutions among the young men and girls as well. So you can see like it is more like more girls into this. And what is the treatment capacity? It is just 30,000 people in a year they can get treatment. And treatment is also provided by the private sector, but unfortunately that is not documented. And when we talk about the treatment capacity, it is mostly male oriented and with limited female specific centers, and the treatment which is available, unfortunately, that is usually provided in the mixed gender and that is not evidence-based or trauma-informed care. So this slide will give you a highlight into the sum of the factors on why women are using drugs in Pakistan. And it is not substance abuse is not about the substance itself. It is most deeply connected in emotional distress, unsafe relationships, chronic stress, caregiving burden, and trauma. And we have seen that if the family or the partner is using drugs, mental health vulnerabilities, caregiving burden, and in addition to intimate partner violence and trauma, they make the women more vulnerable to drug addiction. So we have seen that there is a both trauma and substance use are deeply intertwined. One fuels the other. Many women in Pakistan, they use substance. They have actually experienced trauma from gender-based violence, poverty, or social stigma. So substance use becomes a coping mechanism to numb emotional pain, anxiety, and shame. Over time, substance use itself creates a new layer of trauma through violence, social exclusion, or exploitation. So this creates a cycle of trauma and addiction where pain drives use and use deepens the pain. And there are a lot of myths related to trauma in Pakistan. I will and challenging those myths is very important because this is actually a very important element in providing trauma-informed care. I have chosen some myths. They are very common and we see in the clinical practice. I would like to share it with you. The most common is like good women stay silent about their pain. We have seen that we understand as a professional, healing begins when women feel safe enough to speak. Another myth is like if a woman experiences abuse, she must have done something wrong. Unfortunately, victim blaming, that is very common across the cultures. And we understand that abuse is never the victim's fault. Another myth we see is emotional trauma is not real. Women are just too sensitive. And we know that emotional trauma can deeply affect mental and physical health. And trauma responses are normal biological responses to the overwhelming experiences. And one common myth is marriage or motherhood will heal her trauma. Trauma requires safety, support, and healing, not role expectations. And another common myth is like therapy is unnecessary, faith and patience alone will heal. Faith can be a source of strength, but professional support also matters. So challenging these myths is very important. And there is a vicious cycle of neglect. We have seen the women who are able to enter in the treatment. Usually the treatment is mixed gendered. So they face re-traumatization due to lack of safety and gender sensitive care. And if we do not address trauma, recovery remains incomplete. Relapse risk increases and healing remains superficial. So I believe trauma-informed care is not optional. It is an essential part of like breaking the cycle of addiction. So as Malka was talking about, there are a few barriers. I have chosen a few, like why the women, they resist to access trauma-informed care. And most important is like family reputation, fear of losing children, marital risks, social stigma, cultural constraints, exploitation by the quacks, and most importantly, there is like dearth of expertise. There is no trauma-informed care services available. So the perceived benefits, they are much lesser than the perceived risk in the treatment setups. So I'll be talking about what are the treatment strategies which are we using at Greenfield Hospital of Psychiatry. Greenfield Hospital of Psychiatry is the state-of-art facility which provides gender-sensitive, evidence-based, ethical, treatment to the people suffering from substance abuse and mental health, with strong emphasis on privacy and confidentiality. And these are the six principles of the trauma-informed care. And we all know that they include safety, trustworthiness, uh, peer support, collaboration, empowerment, and cultural and gender responses. I will not explain those principles. I will rather focus more on how we translate those principles into into our practice at Greenfield Hospital of Psychiatry. So let's see how we are able to translate them into the practice. The first and foremost principle or aspect of the trauma-informed care is treatment environment. So we at Greenfield Hospital of Psychiatry, we really see that physical environment and psychological space, they matter a lot. And we approach the treatment from the complete context of the women's life, fostering safety, respect, and dignity, where the staff support is continuously available. And we screen, the next important strategy is screening without re-traumatizing. And we promote gentle, like permission-based inquiry. Like I can ask my client, would it be okay if I ask about stressful or difficult experiences? We do not push for full trauma disclosure in early sessions. We focus more on stabilization and therapeutic relationship. So in order to promote stabilization, we used micro coping skills that actually promote how to manage the distress in the moment. And some of the techniques we use in early stage and to promote stabilization, they include deep breathing, box breathing, and brief progressive muscle relaxation. They help the patient to manage the distress and in the moment, and also learn how to regulate emotions in the longer run. With the supportive and engaging environment, treatment, it is very much important aspect of the treatment environment in trauma-informed care is like communication. We listen to our patients and we keep them informed. What this does is like it creates safety, it creates it removes fear or uncertainty, and it improves collaboration and mutuality. That is very important strategy to promote trauma-informed gender sensitive care. And when it comes to the women, we have seen that it is very critical to work with the shame. And that is like another key aspect of trauma-informed care at our hospital. We separate the person from the problem. We externalize the shame. We tell them the problem is not you, it's what you have been dealing with. And we avoid judgmental or confrontational styles. We lead more with validation, empathy, and compassion. And that is very important. And treatment environment it is incomplete if we do not like actively engage with the patient. We try to keep our promises. The staff is very helpful, and we address complaints whenever they come to us, and we also need like extra step whenever it is needed. These are very small steps, but these intentional small steps, they really help to build a strong therapeutic alliance with the patients. And we trained our staff to remain respectful, to remain patient, and be positive. Like we try to create a calm and positive environment where healing flourish. That is the main goal of the treatment facility. And we understand as women, they have like caregiving roles, they have household responsibilities, they have societal pressures. Sometimes the standard protocols of the treatment, they do not fit for the women. So what we do at Greenfield Hospital of Psychiatry, we do flexible care planning. I'll share two examples are that like we organize shorter sessions for the women with caregiving roles. And we also arrange phone follow-ups when attendance is difficult. So main goal is like how we can improve the retention, keeping in view the women's realities. And another very important component of the trauma-informed care is peer support. And that is the most um, very close corner of the Greenfield Hospital of Psychiatry, which is close to my heart. Like this is like Recovery Lounge, which is an open, safe, free space for the women. With the women who are in recovery, they engage with each other, share their experiences, connect, and promote each other, and kind of provide a peer support and a mutual support. That is like the most important part of the gender sensitive trauma informed care at our hospital. And trauma informed and gender sensitive care cannot be completed without psychoeducation and involvement of the family members, as Malka mentioned. But the key is like we do psychoeducate and involve family members, one, with the permission of the patient, and also we involve those family members who are like recovery supportive. So they are able to understand the trauma, addiction, and how the family support can be a positive recovery capital in promoting long-term recovery. Because we have seen in our practice, like when the family knows about the women using the drugs, the chances for the women to get treatment, they are like 0.00001%. Most of the family members, they leave them, and they're forced to move out of the home, and instead of providing support and the treatment. So that is very important component of the treatment. And another essential element is of the trauma-informed care is training the staff member. We regularly train the staff member in trauma-informed care, and we continuously supervise the staff and caregivers with the vicarious trauma, because we understand that emotionally sound and stable staff can support in promoting healing and recovery. And the next component of trauma-informed care is cultural competence. We have seen that women cannot recover in the spaces where they are not culturally safe. Cultural competence and cultural humility, it is like very important part of when we plan treatment for the women. So this is how that is the one example of cultural competence. We have more female clinical staff to support women in recovery, so they feel safe, trusted, and encouraged to talk, and we promote their long-term recovery and healing. So Swiss trauma-informed and gender-sensitive care at Greenfield Hospital of Psychiatry can be best explained as a safer model of care, and where the S stands for we put the safety first, and A, we acknowledge trauma, we do not ignore it, and F stand for the flexible services. We adjust, adapt treatment strategies to the women's context and their realities. And E stand for empower, don't judge, we do not judge women. And most important, relational context matter. It is very important to involve the family, community, and to have their support, and to have their like Mulka was mentioning about a recovery work that is being done in the Europe, and particularly I had an opportunity to experience a great work done in the UK, and where I saw like how they celebrate women, how women in recovery, how they have make it more like public, and how the community is supported. So the relational context matters. For us, at the Greenfield Hospital of Psychiatry, it is just not a safer model. It's not just a framework. It is a strong commitment to promote long-term recovery.
One more
And
minute.
Yes, I'm about to finish. So we promote post-traumatic growth, and we really want to go that recovery should go beyond the survival and into long-term. And we really want them resilient and focus more on empowerment and self-discovery. And we do a lot of advocacy at local and international levels. So we really want that integration of trauma-informed care into policy and practices. So there is a one international framework that is called SAPI, and we are the part of it. And I really want Cressida can share the link, and we really want you to join that global initiative to understand better trauma and creating a trauma-informed care. So I'll conclude with this: like one, when care is trauma-informed, gender sensitive, and rooted in dignity, recovery becomes sustainable. So the floor is open for questions, start, and comment. And thank you very much for your time and effort. I really appreciate that.
Thank you so much, Azia, for a great presentation also. For not only showing the importance of gender-sensitive treatment, but also adding other additional components such as trauma-sensitive care, as well as cultural sensitivity and competence, and also, of course, also what Monica said earlier about training the staff. It's so incredibly important, and creating and giving such good insights and tips in what organizations could do to make it safer and more approachable for women to enter treatment. So thank you so much for that. With that said, Azia and I, we discussed a bit on how we can learn more from the participants as well. So I'm just going to open up a question, a word cloud, for you to answer, because we want to see your input also. I'm just gonna share my screen, and I think it should also be in the chat. You should be able to enter it, open it. Just 1 second. Just some technicalities. Yes.
I can
Let
see
me
it in
share in the chat.
yeah, but it says like poll is closed.
Closed, yes, because I opened it too early, so I needed to close it again. So this is the Slido, just for everyone. You can scan the QR code, or you can also go to the website slido.com and enter this code. Just giving you 1 second before I continue and to join in and opening up this question. Sorry. So the question for you, we would be interested in, because we are Asia has talked about myths that have been there in, for example, Pakistan. Safi, she mentioned, also created a myth to action toolkit, including these myths. I know that maybe Elroy will also share a little bit there, but we want to hear more about what kind of other myths, besides the ones that Asia has shared, are existing in your community that should be debunked. And then maybe Asia, as they come in, maybe you can go into them a little bit and share on how we can debunk these ones. For example, the first one, addiction is a choice and also moral failing. Have you heard that one before? And what have you, what kind of steps or tips can you give in order to debunk this one?
Thank you very much, Krisidan. And thank you for sharing this myth. That is very common, and that addiction is a choice and also a moral failing, particularly when we talk about the culture from where I am coming. It is addiction is more taken as a moral sin instead of a disease. So most important, like thanks to the science, they have told us like addiction is a biopsychosocial disease. They have actually told us like how when when someone uses the drug, how the reward circuit is actually biologically activated, and how it is the disease where there is a neurochemical imbalance and there is a change in the way we think, feel, and respond to the situation. So that is I'm really grateful to the science that they have told us like it is a disease with the brain and body is involved. And when people say it is a choice, I have seen in 19 years of the experience, like they start drug in a, because of the peer pressure, because they like it, and because they just wanted to feel good, and so many things. But when it becomes a substance use disorder, it does not remain a volunteer action. It becomes a disease. It is not a matter of choice anymore. So I hope it is helpful. And
Definitely. Thank you, Asia. That also kind of goes into the two that were shared regarding witchcraft and being bewitched when one is facing a substance use addiction. Just with what you said, with the knowledge and the research that is out there, that this is disease and what it does to the brain and also the body. We know it's not something that is done by bewitchment, but it is something through education and raising awareness and educating those in the communities that this science is out there and that we should not disregard the persons facing substance use disorder. Similar with the myth, one can stop whenever they want to. I think this is also something that Mulka already mentioned. It is a very long process, usually, like 18 years, I think she said, from the moment of onset addiction until sustained recovery. It is a long process, and it also is not a linear process. I don't know if you want to share a bit more on that too.
yes, are you asking Mulka or you are talking to me?
No, you.
Oh, oh, sorry. Because yes, you have mentioned it well. Like one can stop whenever they want to. Malka has already explained it. Like once you are dependent, and once you are with a substance use disorder. Uh, to stop or immediately quit, it is not possible, particularly when there are co-occurring medical and mental health disorders. Then the professional help is very important, really, really important. And in my presentation, I spoke about Safi like very quickly because it was like a lot of time. And in that, if you go and check with that initiative, we have actually debunked many myths from different parts of the world. And that debunking is not just like I say something, oh, it happens like this. That debunking and challenging the myth is like is in pure with the pure science, like how the science explains this. So that is also a very good initiative to look in that. That is the great effort of WFAD and Drug Free America Foundation and Roche. That is also, I would like if you can share the links so people can also be the part of that initiative as well.
Thank you so much, Asia. I have shared the link in the chat for those interested for Safi. You can enter the chat for that. Thank you so much, Asia. The time is moving fast as always. So with that, I would like to move on to our next speaker. But thank you so much for your presentation, also for interacting in the Slido, and thank you for all participants to interact in the Slido also. With that said, I would like to introduce our next speaker, Elroy Sturman. He is a social worker currently in service of Department of Social Development, Riversdale, for the past 5 years, and he is a substance use program champion for the service delivery area and works as a generic social worker and is responsible for coordination, implementation of substance program deliverables and local drug action committee with the different community stakeholders. Thank you, Elroy, for joining, and the floor is yours.
Thank you, colleague, for that introduction. And firstly, thank you for the opportunity to share our work here in the field. I think what I've gained from the previous two speakers is that this is a very important job that we are doing, and there's a lot of challenges that we're experiencing. So, and I'm going to speak more about that. Let me just share my screen with you guys. Okay, so I can share my presentation also. Okay. Okay, so I'm gonna immediately start with my presentation. And again, thank you for this opportunity. So I'm gonna start with my role. I started as a substance social worker in 2022 when I started with one of my other colleagues, and immediately this field actually activated my skills and my love for substance clients as well. So where is this part now? Okay. Um, I rendered more community-based addiction services in the Esekwa community. We have 8 towns here. We have a quite vast municipality, and the support group development and aftercare services that fell mainly my responsibility when I started doing substance services in the communities. So just more of a background, we are working generic now for the past 2 years, but initially I started off as working more specialized in the field of substance services. And 2 years ago, we started more with a generic approach where we rendered services generically in older persons, substance use, VP programs, and all of that. And we worked as a more intersectoral collaboration with the municipalities and our local subs officials, because we have 4 subs service stations here in the Esekwa also. Um, the second part is that the focus of recovery orientated care for me was more about when I started, when I learned that we need to take a different approach to substance services and how to reach the service users with regards to addiction care. And the person-centered approach and the strengths-based approach was the more relevant one. And like we've all learned in varsity, that we need to focus on the person. There was a mind shift paradigm with regards to that, and starting to work more holistically and more trauma informed, like the previous speakers also emphasized on, and more on family and community involvement. I know each community is different, and we've because all of the towns that we are servicing is a different culture. So we had to focus more on how you can make the treatment more relevant to the different communities and to the different service users, and focus more on long-term recovery and integration focus. Because what I also found was that if you don't work person-centered, then you can actually lose the client, and you need to focus also on empowerment and more peer support. And I will speak more about that later on in the other slides, and more holistic and trauma-informed care, because even over the past few months when there was a lot of focus with our webinars that we had, um, the highlight was for me that we can't work in a silo with regards to, it's not just the substance. It's more about where did the substance come from? Why is the person doing the substances, and why is it had such a big impact on this person's life? So we look more at trauma-informed care, and I think that's the highlight also that the other speakers emphasized there. And then I want to go straight to some of the challenges that I've experienced over the past few years working with addiction care in the community. I identified there was a limited aftercare and support services. So we have these skilled professionals in the community, in service of the department, and even the other social workers. But I think there was a gap in bringing the service to the client, or making the client aware of the service that we have here that we can offer to them. And I think also there was a clear lack of specialized addiction professionals, because we work specialized at the time, but it was only one worker for 8 towns in the Esekwa. And I think there was a big mind shift with regards to that because we started working generically in substance now, where there was a request where everyone had to do substance services. So now we are actually everyone kind of specialized in that sense. And there was almost every time you find the link between substance use and the link between crime and trauma. So that's where it started also for me when I started working as a probation officer at court, where you had to find the link with substance and then the link to crime eventually, because many of the persons that we assessed, even the children and the adults, there was almost 95% there was a substance use, underlying substance use or exposure to substance abuse behaviors in the children's families or in the client self. And that's where we started developing a program where we can basically strengthen the department's hands in the communities, where me and one of my other colleagues working at the time started the substance mentorship program, where we went out to the different communities and we basically tried to present this idea of how can the community get more involved with regards to substance services, provide support, because there was a clear lack to that, because we are only available certain times of we are only available certain times of the day, like 8, 7 until 4 o'clock, and then Monday to Friday. So what happens after that? And you find that most of the time clients get involved with substance use, children get involved with substances in crime after hours when the social worker is not available. And we worked it out for the different towns. So we actually received a lot of support in the different communities, where we were able to get between 15 and 20 substance support mentors in the beginning with the first rollout of the program. And that was a good thing, because now we also received support from our other colleagues in the municipality and subs, where they were able to actually buy into this opportunity, where they can also get be involved basically in that. So the implementation started in 2022, and we started going on in Albertinia, Riversdale, Slangerveer, all these different towns. And I know some of them were playing dual roles as well. So we have these substance support mentors, but they are also, for instance, working at the police station with providing trauma support services to people or children, for instance, that have been victims of gender-based violence. So they are actually quite equipped to provide the service. So now they're also working from a trauma informed point of view, and that is, I think, that makes it special and make it more effective in that sense. And they were also provided during the training with the basic counseling and support skills. We focused a lot on non-judgmental engagement, that we provided them with guidance, support, because they are also in the community. We need to understand that they were also the ones who really work with the people when they're in the most vulnerable state, because many times we receive the clients when the crisis is already subsided. So we are entering in the aftermath of everything. And then the self-care and ethical practice of these volunteers, and many of them also have family members that has been addicted to substances, who's also service users. So they understand better than anyone on how to deal with these people. But there's also fine line where they had to, like, be aware of themselves and their own trauma in the end. And they were able to do after our home visits, medication adherence and support services, especially with this substance abuse clients that is a dual diagnosis, when they have substance-induced psychosis. So they are the ones who are the immediate contact when the police calls them in for providing the service, and then they contact us with regards to that. And then they are linking services with the community systems, where they are able to link service users with the support groups, with the clinic, with subs, and provide their generic guidance and support to these community members or the service users in the end. Um, just and then we started looking at how can we expand this whole program, and I started with the 2022 year with the first pilot of aftercare group support for persons that have been to the rehabilitation treatment center, because I identified that in that year between 2021 and 2022 April, I think I applied for 6 clients in the year to receive aftercare services, and that just made it better for us. Now we have this group of people, and we initiated the aftercare and support group, and that went well. So we moved it to Albertina as well, which is a more bigger town in the Essequa, and I think the prevalence of substance users are also very high there. And the initial support group attracted around 25 to 30 people per session. And that was also a great start for us. And that's how I identified some of the other support mentors, people that went into recovery that could provide now a support service to the other people in the group as well. And we established another support group in another town. So these little pop-up mushrooms were also there, where we were able to strengthen the service, but we had a difficulty of not having enough staff, to run these groups in the end. So that's still a challenge, but we at least we are able to provide the service to the community members and get them involved also, where there was a focus again on the person, and we focus more on the ecosystems approach, trauma-informed intervention, in exploring the root cause of addiction care and the link between the substance and the crime, because many of these people that I was able to assess was then ultimately referred by myself to the substance support groups. And one thing that worked well for us in the community and working with the courts was being able to advocate for clients that or that you assess that is a substance abuse challenge. And this person, due to the substance abuse, has now committed crime to basically feed his habit. And being able to stand in court and testify and promote services of, what, instead of being punitive in the sense in referring the person for long-term prison sentence, can't we look at maybe referring the person in terms of the Criminal Procedure Act to a rehabilitation center? And that also worked well, because now we are moving away from the criminal justice system and trying to provide more rehabilitation services and getting that person as a functional community member again in changing these type of behaviors. So yeah, that's where the stakeholder collaboration also comes in. I think in our community is very unique. We have a good relationship with our local police, and then the municipality, where we have the partnership, our memorandum of understanding as well, and then the local drug action committee that we started in 2024. I know the next speaker will speak more on that also, because he was involved with the peer recovery and the allied training initiatives, where we started that last year. We identified these are the people in the communities that is actually able to assist and help, and that has been involved in the community. So we are willing to provide this training to them, and they are able to bring it to the ground and assist with more support services in the community. Um, and the household profilings that we started in the local drug action committee, or as part of that whole program, was actually quite helpful, because now we were able to identify more persons that needed the service, and we had the substance support mentors, the peer allies that's also involved in this whole process. And we built further on this by trying to get these people more involved in trying to provide a type of incentive where we were also being able to provide a project plan to the community, the local municipality, where we were able to involve them in training, and they were also getting a stipend now as community workers, where they are able to provide the service but also get the incentive. And we piloted that plan this year, and we already have two substance support mentors and peer allies that's actually working in the community, and that's part of this whole project. So it started basically from the peer mentor support program and escalating to the peer ally program, and now we are actually looking at expanding this whole program and looking more into how we can get more people involved and also lead to other communities in the Essequa. So that, with that said, I'm going to move forward to the Myth to Action Toolkit, where it was also part of the LI training last year, where I had the opportunity to present this project in one of the training sessions. And it actually went quite well because there was a good response in the end to this Myth to Action Toolkit. And not many of our clients, all of them were Afrikaans speaking, and I had to translate it, and it actually worked out well because it opened the floor for more conversation between these people, and they are the ones who was able to go and challenge themselves and the people in the community with regards to the stigma. And I really believe that it opened the floor for me also to think about how can I approach things differently in the end, because I had the opportunity to actually now go to different groups in the community and present the Myth to Action Toolkit, and where we had to have a discussion with regards to the myths. And it's mind blowing how people actually didn't realize what their preconceived ideas and stigmatization thoughts were with regards to this. And I was also able to I was invited to the national launch of it and share our ideas with regards to how the people experience it. So that was also quite a good reflection for me.
One more minute, sorry,
Mm.
Eroy.
Okay, no, it's fine. So I was able to focus on the person and the addiction, and just to I think I can skip that part. For me, it was community collaboration that made this thing very important for me. And the peer support improves the sustainability, integration services, and improves the outcomes as well. And it provides hope and dignity to the community members and the persons that suffering with these addictions. So that's basically it. And I want to thank you guys for the opportunity.
Yes. Thank you so much, Ilroy, for the wonderful presentation as well, for highlighting all the great work that you're doing on a local level. I'm always very inspired, and you've done so many great programs on different levels involving different stakeholders, making sure that they're well aware of all the, of all, not only like that they're well aware of the situation, that it is a disease, as we said, that to kind of that helps in destigmatizing, also getting them involved and knowing for them the role in their in the society, how they can support people in the community and those facing substance use disorders. So thank you so much for doing all that great work. And also, of course, I'm always very intrigued. I'm just looking at the time because one question I think we can move in before we move on is you share that you conducted a lot of trainings also on different levels, including, if I understand correctly, with the police and also at the drug court, etc. Was there any hesitation that you faced when you introduced such trainings and the necessity of these trainings, or did they kind of approve of it at the very start?
Okay, I think the relationship with the community is important in this sense. There are some challenges that we do experience, but majority of the time we didn't receive any, like hesitation, because especially the sub services, they were very involved with regards to that. Community members, they are always open to get involved, and our local municipality is also very helpful with regards to that. So we have a good understanding with regards to the service and the necessity of the substance services. So they would always provide us with resources to bring these trainings to the community, and like the PLI training and the one that Warren also did. The municipality was central to bringing that training to our local towns. And I think that's the important thing, that we are open and challenged to address this in the end as a team.
Thank you so much. You're definitely right. So it's about building relationships already very early on to then also be able to, conduct the necessary trainings and explanations. Thank you so much for your input and for your presentation. Looking at the time, I would now move on to our next speaker. Our next speaker, and at the same time, while I'm introducing him, I would strongly encourage you to go to the Slido again, which I have posted in the chat, and share your answers to these questions, because they're kind of an introductory question to Warren's presentation. With that, I would like to introduce our next speaker, Warren. He is a community activist, addiction counselor, and lecturer with over 15 years of experience in the addiction and mental health field, grounded in both lived experience and professional practice. And his work spans the continuum of care for substance use disorders, but his passion lies in designing and implementing peer-delivered substance use prevention and recovery support programs. I will also share the screen. Sorry, I didn't do that. Just for the Slido to be active, just for a second, so you can, yeah. The floor is yours, and I'll just leave it open for a little bit for people to answer, I guess, and then you can take over.
Thanks for the introduction, Cressida, and thank you for inviting me to share some insights about what we're doing in Cape Town, South Africa. I'm just going to give it a couple of seconds to see what kind of responses we're getting. Yeah. I think it's 1-1. So one person chose isolating people, and then another one chose social connection and inclusion. It's community support. Yeah. Yeah, so definitely. So these questions might seem like a bit strange asking that, or having those certain answers in there, but actually that's kind of what happens in our communities, where people still think that isolating people living with addiction and mental illness from others is the way to go, the way forward. Increased punishment for substance use is the way forward. So this just highlights how how we're still dealing with substance use disorders in our communities at the moment. Okay, I've got a very little time. I've got less time than the other presenters, so I'm going to crack on with my my presentation quickly, because I've got so much to get through. Can you see my presentation?
Yes, perfect.
Okay, perfect. So as I was introduced, my name is Warren Cornelius, and I'm one of the organizers of the Recovery Walk Cape Town. So I've got so much to get through in such a little time, so I'm going to skip through some of the slides and information, but we're going to get to the crux of what we're doing at the Recovery Walk Cape Town. So essentially what the Recovery Walk is just move this, is it's an annual public recovery celebration that's held in Cape Town, South Africa. It's entirely volunteer-led and free to attend and open to anyone and everyone. So what the Recovery Walk does is just we essentially celebrate recovery from addiction and mental challenges while creating a visible and inclusive recovery environment. So what it does is really provide sober public space where people in recovery, their families, professionals, allies, and community members can come together in solidarity and hope. So importantly, the recovery walk demonstrates that recovery is not only possible, but that people in recovery can live meaningful, connected, and contributing lives. So this is just what the recovery walk is generally on paper, as this annual event, volunteer, all these things, but actually it's much deeper than this. It's much more than this on a practical level. So what the recovery walk does, although it's an annual event that happens, there's a gathering of volunteers and people in recovery, people with lived experiences, also recovery allies and people who are supportive of recovery. We get together on a monthly basis to organize this annual event, right? And that means people coming together to share their recovery experiences. That means people coming together who don't necessarily have recovery support, where stigma is rife in their communities, but this gives them a space, a safe space where they can come and share their experiences that's happened over the past month, and come and connect with people who've got similar lived experiences as they do. So it's much more than just this recovery annual event that happens. It's a building of people, a community of people in recovery and people who are supportive of recovery, and celebrating that freedom that comes with that, and that connection that happens on a regular basis throughout the year in planning this annual event. So it's far more than just this annual event that happens, but everybody who gets together and comes together to organize it, because I'm just one of the few organizers, but there's dozens of volunteers that make this event happen. And they're generally people with lived experience, people are in recovery themselves. So peers generally that kind of help us get the event off the ground. And so, yeah, I thought it was important to say that, because looking at the recovery walk Cape Town, we can look at it from different perspectives. There's people who takes part in the recovery walk, or just like the general public. There's also people who are participating as a volunteer in the recovery walk. So there's different elements to the recovery walk. And I'll kind of go through each perspective as we go along. So why recovery visibility matters, right? So obviously we spoke, Malka spoke so nicely about the barriers, as well as Asia. So one of the biggest barriers, as we've heard, is to sustain recovery, stigma and social exclusion, right? So people in recovery continue to experience shame, discrimination, isolation, and limited access to opportunities such as employment, housing, and social belonging. So the Recovery Hawk Cape Town challenges these perceptions by making recovery visible in public spaces. So when communities see real people openly living in recovery, it changes their stereotypes and creates hope for others who may still be struggling. So visibility helps shift recovery from something hidden and stigmatized to something recognized, celebrated, and supported. So this is something that I'm quite passionate about, is being open about my personal recovery. Because if we look at me now with all this gray hair and the way I look right now, you never say this guy is in recovery from a substance use disorder, but that's exactly who I am. This wasn't who I looked like more than 2 decades ago. I had a very different life then. You know what I mean? But it's important to show people that despite how they feel about and see me and how I present right now, I'm somebody who's in recovery. And just like I find recovery, anybody can find recovery. And recovery is much more than just going to treatment and receiving aftercare, because we know that only around about 5% of people who actually need treatment actually receive the treatment they need, right? So recovery is far more than just aftercare. Recovery is, like Malka was explaining, it's a process of change. There's all these various definitions of recovery, but ultimately that's a common denominator amongst all these definitions, is that it's a process of change. Okay, next slide. 5 core contributions that we have with the recovery. Firstly, we challenge stigma and social exclusion by demonstrating the successes and achievements of recovery. Secondly, we create visible and accessible recovery community that engages the public. Thirdly, it ensures diversity and inclusion across ethnicity, gender, age, culture, and recovery pathways. Fourth, we build meaningful partnerships and pathways to community resources and support systems. And lastly, it champions the positive contribution that recovery communities make to society and civic life. That's what Malka was speaking about, how people in recovery are more likely to volunteer, more likely to be actively involved in civic life. And that's kind of what we highlight in our recovery work. So these principles position recovery as a community strength rather than a hidden problem, right? And you will see here, if you look at the pictures, I'm just gonna go through them quickly. You'll see here one of our This is me standing here and talking to one. The last is Recovery Walk. So Recovery Walk is also a space where we share information. One of the previous speakers was speaking about it's important to share information and education about substance use disorders and mental health. So to give people the better knowledge about what's actually going on, what's the landscape looking like, dispelling myths, giving truths to people, educating people, and I particularly like what Asia was saying, and what I like to call it is mental health literacy. We need to educate people and inform people and better improve people's mental health literacy so that people have a better understanding of what addiction is, what recovery is, what is a mental health condition, etc., etc. Because the more informed people are, the better they respond to situations, or better they respond to these different conditions and disorders. I'm running through this because I want to set on one specific slide later. Core contributions. So partnerships and community impact is essential. So this is particularly important to me. So recovery-orientated systems require collaboration beyond treatment settings. So Recovery of Cape Town, we focus strongly on partnerships and community engagement. So the walk brings together treatment centers, grassroots organizations, peer support groups, families, researchers, faith-based communities, civic structures, and the broader public. I need to highlight that the people that we struggle to get most to join the recovery walk are mental health professionals or medical professionals. People in the healthcare profession are the people we struggle with the most to get attending a recovery walk. The others, grassroots organizations are easy to attend, but it's the care professions that we struggle to get. So these partnerships help create pathways to support connection and reintegration. They also strengthen the recovery capital that Malka highlighted, the personal, social, and community resources that support long-term recovery. So one of the big highlights that we had last year was we started a relationship with the University of Cape Town, and we actually had our first university-based recovery walk. So it's all the students got together at the university and got together for our own University of Cape Town recovery walk last year. That was huge for us, and you'll see these pictures here. These are students in the pictures in this slide specifically at the University of Cape Town's recovery walk, and it was a huge achievement for us because we know that through studies that the university is like a microcosm, so they kind of represent general society as well, and university students also have in need of support, specifically substance use and mental health support services, recovery support services. So yeah, so that's something that was a huge thing that we achieved last year, and the universities decided to carry on this year. So we kind of want to get in talks with more universities because we see the need and we see the benefit of having university-based recovery walks as well, celebrating recovery at university campuses. I'm going to speak about limitations and barriers to our visions and what we're trying to achieve as well. So families and communities, this is also of utmost importance. And these are pictures from our previous recovery walk. And you'll find kids, grandmothers, and everybody at the recovery walk. And often you can go to our social media pages where we have interviews with some of these people. And you know what's really heartwarming for me is when I come into contact with a mother whose son or child is still using substances, but she's feeling isolated in her community because she doesn't know where to reach out, and she joins the recovery walk just to come on this walk, and she sees other mothers, other families, other children who are in recovery, and it gives so much more. The recovery walk offers so much more than just a celebration because it gives hope. And it's something that's not quantifiable. You know, when we speak about hope, we don't realize how, I think that's a foundation of well-being, right? And when I see a mother who was hopeless before she came to the recovery walk and found hope in the recovery walk, it just it gives me it fuels my passion really for what are we doing. So the recovery walk doesn't happen in isolation. It's families, peers, and communities that play a critical role in sustaining this recovery. And the walk provides opportunities for connection or reconnection, healing, and belonging. And these families are a very important part of these public recovery gatherings, help reduce shame while strengthening hope, solidarity, and social connectedness for everyone. The recovery walk also acknowledges the close relationship between addiction, trauma, and mental health challenges. So the event creates a non-judgmental spaces where people can openly share their stories and experiences. As public storytelling humanizes recovery and helps communities move away from blame and punishment towards compassion and understanding, creating like really trauma-informed community spaces. The walk promotes dignity and connectedness and hope. This is what I want to, this is the slide I wanted to come to, and I know I've probably only got a minute left, but let me just rush through this. So the Recovery Walk Cape Town forms part of a broader vision, right, to establish inclusive recovery communities now and cities across South Africa. So I know Malcolm was speaking about recovery cities, but I like to focus on communities, like to focus on really grassroots uh, activities. And initiatives, because it's communities, a bunch of communities coming together is what's called a city. So the vision recognizes recovery as a shared community responsibility rather than a solely individual or clinical issue, right? Through partnerships between grassroots organizations, treatment services, families, civic leadership, and communities, we aim to create environments where recovery is visible, supported, and integrated into everyday community life. Ultimately, the recovery, the goal is not only not only individual recovery, but healthier and more connected communities. So what happened? You can see in the middle picture here. I'm handing over our last recovery walk. We actually marched to Parliament, to our Parliament, right, to hand over a memorandum to local government. And this lady is a local government representative. She's in charge of health and community services. And we handed over a memorandum. And one of our asks was to support recovery-friendly public culture. So encouraging alcohol and drug-free public spaces and events that include people in recovery, their families and communities. We wanted them to endorse a recovery walk. But the main thing is to ensure lived experience representation, because we have so limited representation on any mental health or substance use boards, committees, services. Just a quick anecdotal story is that our country is governed by, there's something called the Central Drug Authority, and they're the body that legislates and governs how substance use gets treated in South Africa. But to get onto that body, somebody with lived experience will need to have 7 years recovery time, well, clean time, what they call in the document, and you need to get confirmation by 4 different psychiatrists reports to actually acknowledge that you are actually in recovery. So there are all these barriers. You know how expensive it is for somebody to get one psychiatric report. It costs about 4,000 to 5,000 rand just to go to a psychiatrist, then to get the report times 4, then to go through this whole thing. So there's so many barriers. So there's nobody with lived experience that's actually sitting on the, so lived experiences voices are not heard in any of these bodies, forums and committees that govern substance use and mental health conditions in the country. And that's kind of what we're fighting for, is more representation. And this is all part of this inclusive recovery communities and cities that we're trying to achieve. So, in closing, I could speak much longer on this, but I'm trying to save time and try being mindful of your time, Cressida. So, in closing, thank you very much for letting me speak about this. And one of the things that I do, part of what I do personally is I train people, and I train people on delivering recovery support services, particularly peer recovery support. And that's how I worked with Elroy in the Esequa municipality, training these peers there. But so this is important where inclusive recovery communities come into things, is having recovery walks in different communities. So currently it's in Cape Town, but for us to expand what we currently do, and for us to actually take forward. So although we are a group of volunteers, which means we have our own day jobs, and at night we kind of create this recovery walk in our free time in the evenings and weekends. But if we want to engage with city officials or municipal officials who work normal 9-to-5 jobs, there's no way we can do that. So what we're trying to do, we're trying to get funding to employ somebody on a part-time basis, that they can actually take this movement forward, that they can actually do and further the cause that we're kind of working on at the moment, whether it be expanding recovery walks across many more different communities and towns and cities, and engaging with city officials to create this inclusive recovery city. currently, that's kind of one of the barriers to what we're experiencing. In fact, the recovery walk doesn't fit nicely into any one of the sections on the continuum of care for substance use disorder. So there's no funding available from a state mechanism. There's no state mechanism to get funding. So, and there's so much stigma. So we don't actually have funding from anyone. We were receiving funding from one private treatment center for just to get the recovery off the ground, but we've lost that also last year. So we're struggling with funding and kind of. So if you guys are keen to donate, please go to our Backer Buddy account, and also you can contact me personally on my personal email address here. If you want a recovery walk if you're in South Africa and want a recovery walk in your town or city or community, or want to get involved in any way, please contact me. And yeah, thank you. I had to rush through that. Whew, thanks.
Thank you so much. I mean, you did a great, wonderful job. And you can really tell that you're passionate about it. And I think that is already very inspiring. And you pointed out such incredible things of the recovery walk and the meaning behind it and how much it can mean for a community. And I think it's a very much of a it's easy to copy in a way within our own communities. It just requires some of the effort, the volunteering effort and the connection. So I think people can definitely learn from that. I see some hands raised. I know we are over time, and I'm very much appreciative of everyone who stayed on as long as they're staying on right now. So I don't know if Abu Bakar, sorry if I mispronounced your name, Asani Mahout, is you want to, you have your hand raised if you wanted to ask a question regard to Warren. You can unmute yourself if you want to, or maybe it was an accident.
Kristen, I was hoping you could play that video as well today still,
Yeah,
but let's see
I
if we
will
can.
do that right away. Yes, I was going to do that next. So also Warren shared a video kind of summarizing the recovery walk of this year. So here you go.
See you smiling, put on your dancing shoes. Cape Town, welcome to Dina Kanakina, Dina Dina oh. Dina Kanakina, Dina Dina oh. Oh oh. Kana 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 Kanakina, Dina Dina oh. Welcome to Cape Town, oh, enjoy the party. Come on and have some fun. Cape Town's number one. Welcome to Cape Town. Let's see you smiling.
Wonderful. So many people sharing, joining that recovery walk. That is so inspiring. Considering the time, I think if anyone has more questions to you on how they could organize such events, what is required to organize such events in their own community, they can most likely reach out to you personally. So they can even ask us for your contact details, or you already shared them on the slides also. So I really encourage those who are interested to organize recovery walk in their community, to reach out as much as possible. With that said, I would like to officially close today's session, and I would like to thank all of the speakers for their valuable contributions, and also, of course, all the participants of joining us today and interacting through the Slido and the chat. We really appreciate you having been here today with us at our third session, and yeah, it really showed today with all the speakers that creating gender and trauma-sensitive treatment and recovery sponsors requires not only evidence-based approaches, but also compassion, community engagement, and a commitment to reducing stigma. So we hope that today's session has sparked ideas that you can take back to your own organizations and community. And we will look very much forward to continuing his learning journey. And with you in our next session next week, same time, same day. Very much looking forward to welcoming you there then. So for now, wishing you a wonderful evening, day ahead, and looking forward to seeing you next week. Thank you so much to everyone.
Thank you. Thank you.
Bye-bye.
Bye.